I invite the next speaker, Dr. Vikas MITTAL, to talk about evolution of transplants from PK to DMEK and beyond.
Thank you so much, Scientific Committee, for the opportunity. We started with future, and Dr. Paras said what we are doing the present. So I'll just tell you that how we cornea surgeons have evolved over last decade and a half specifically. So this evolution is actually has been a revolution, and this last 1.5 decade has made this cornea per se very glamorous, because we can do a lot of new surgeries that we were not doing 20 years back. I did my fellowship in 2005-06, and what I practice now and what I used to practice back then, there's a huge difference. At that time, we had only one terminology to remember, that is PKP, penetrating keratoplasty. That's it. And now we have so many things that has come up in last 15-20 years, which has the basic reason for this coming up of these things are we as cornea surgeons, we want to transplant only that layer which is defective rather than replacing the whole cornea. And it's not that penetrating keratoplasty has been a hugely successful surgery, and still there are cases where we have to do only PKP, and it's a century old surgery. But the issue is sometimes suture related. So can we do a suture-less keratoplasty in few cases, and then we have rejection, so can we just keep endothelium? So those kind of thought process evolved over time, and we thought that maybe we should replace that layer which is defective. So I'll take you through how individual layer is transplanted. I'm going to show you few cases, few videos to just make you aware what all these terminologies stand for. So first, we all know that this epithelium, and Dr. Paras has nicely covered. So these are the cases where we don't have a transparent corneal epithelium. Instead, we have a conjunctival epithelium, and we want to transplant. So we cannot do a penetrating keratoplasty here. Even if we do, that will fail. So for that, we have to replace the normal corneal epithelium. The technique Dr. Paras has already shown. So what we do is, when we place these individual transplants, and it covers the whole cornea, and you can see on the left side is an opaque conjunctival epithelium, on the right side we have a transparent corneal epithelium. And if down there the stroma is opaque, you can always go ahead and do a penetrating keratoplasty to make these patients see. And the main revolution in this particular technology has been the slit, and that has made the life very easy, because you don't have to depend on a stem cell lab, and it lasts so long. So this was my patient who had undergone slit 14 years back. So it lasts so long, and it's been really successful. So first, if you have an epithelium, so replace only epithelium. So next come the Bowman layer, where the Bowman layer is defective or where it's problematic. So in keratoconus, we know that Bowman layer is fragmented, and it has been postulated that this is a main reason for this ectasia to progress. Dr. Jared Meles had thought that maybe if we transplant only Bowman layer in the cornea, this will stop the progression of keratoconus, and they found pretty good results. But if you do it in your wet lab, it's quite cumbersome, and you tend to have a lot of perforations in that. So you can always do a Bowman layer transplant using anterior stroma as a vehicle, which makes the surgery technically or surgically very easy. So what we are doing here is using a femtosecond laser in the patient's cornea, which is a progressive keratoconus. We are making a tunnel using a femtosecond laser, and then we are mounted the cornea on the artificial anterior chamber, and then harvesting the anterior 180 to 200 microns. First off, it's very important to remove this epithelium so that you don't have any epithelial ingrowth, and then mark this limbus, and then you go ahead and just harvest anterior 180 or 200 depending upon what's the pachymetry. So this will have a Bowman layer, and the vehicle that we are going to use is anterior stromas, just to make this surgery simpler. And then we take the patient into main OR, open this pocket that we have created using femtosecond laser, by using any blunt instruments, and then we use the inlay which we have harvested. We load it into a IOL injector, and using this injector we just push this graft in the mid stroma. Generally, we reach around 180 to 200 micron layer pocket. So we use an IOL injector so that you don't have this conjunctival secretion or those things go inside, and unfolding is very easy, and this will become a sutureless transplant. So, and then at the end you can place a bandaged contact lens just to make the patient comfortable, and this is how the patient looks like in the post-op. You don't have interface. The interface is similar to what we see in the LASIK, as you can see here, and you increase the pachymetry, and increase in corneal thickness is very predictable in these kind of cases. And if you see over a period of time, we see that the ectasia stops. So if there is a progressive keratoconus, that stops, and this efficacy is almost similar to what we see with the cross-linking, with an added benefit of increase in pachymetry. So we had compiled a few cases. These were, I think, 16 cases where one eye had undergone cross-linking, other eye had undergone Bowman-Stroman inlay, and we found that both the patients, group was, the keratometry was stable and pachymetry improved. So there are different names given to it: additional keratoplasties, stromal augmentation, mid-stromal keratoplasty. The idea is that use a Bowman layer, transplant it along with some stroma without removing anything. So this is how we transplant a Bowman layer. So epithelium is done, Bowman layer, next is stroma. So this patient who had a healed fungal keratitis, vision of 2400 and a scar in anterior 200 microns. So what do we do with these kind of patients? Should we do a penetrating keratoplasty? This we used to do 2 decades back, but now if you have a scar only in the anterior stroma, you can just do a superficial anterior lamellar keratoplasty using, if you have a microkeratom. With microkeratom, all you have to do is just make a free cap from the patient eye. So this is a free cap that is done. This remove this cap of anterior 180-200 microns, then use a whole globe, and over a whole globe use that microkeratom same again and create that flap of the similar dimensions and just place it over the patient's cornea. It's just like you manage a free cap. Similar to that, you don't have to put sutures. Use a 2-aerosol sponge, ensure that all interface fluid drains out, stay there for 5 minutes, and the surgery is done and you don't need any suture. This again becomes a sutureless keratoplasty. Same patient, 3 weeks, 24-40. You can see the scar has been replaced by anterior stroma, and that's when the scar goes and cornea becomes clear. If you have an access to femtosecond laser, great, that becomes even more simpler, and there we will call it femtosecond assisted lamellar keratoplasty. Same thing, the 200 microns from the patient side, 200 microns from the cornea, and just place it there. So this is what is FALK or SALK stands for. But if you have the whole cornea that is involved, right, like advanced keratoconus, or if you have a scar which is in entire stroma but your endothelium is healthy, then you don't have to do a penetrating keratoplasty. There is where we do a DALK, where you leave endothelium, desmoid membrane, and some maybe stroma. So this here what we are doing is just removing the stroma. The whole stroma is removed, and from the donor cornea we remove the desmoid membrane, and then we simply suture it over the cornea. You can see the patient how they look like. So you can see the ectatic cornea becomes flat and endothelium belongs to the patient only. So that is what the basic advantage is. As you can see here, post-operative 2 years, you can do it in scars, corneal dystrophies like macular dystrophies, even the acanthamoeba keratitis. If you have anterior one only and the patient is not responding, you can do a DLK as well. And there was a very good study from LVPI. What did they compare the 2 groups in which the DLK as well as penetrating keratoplasty, although visual outcome is same. But look at this, endothelial rejection. So most of the rejection, causes the failure. So there will be no rejection or very little chances of endothelial rejection because the endothelium belongs to the patient. Epithelium, Bowman layer, stroma. So last comes desmoid membrane. So if you have a pseudophakic bullous keratopathy or any condition where endothelium is not working but stroma is healthy, so we don't want to do a penetrating keratoplasty in these kind of patients. We will replace or we will transplant only endothelium. When we transplant desmoid membrane using posterior stroma as a vehicle, we call it DSEK. And when we transplant only desmoid membrane, we call it DMEK. So this is how a DSEK looks like, and this is how we generally do DSEK. So first of all, what we are doing is mounting the tissue on the artificial anterior chamber, dissecting it. The idea is to get the posterior 1/3 of the cornea, and then from the patient eye remove the descemet membrane and then transplant it using a Busin glide, or there are many other glides. All you have to do is and then secure it with the air. That's all, and the surgery is done over. So this is how, this is my first DSEC close to 15 years back, and these cornea, they starts getting clear and without a use of surface sutures, right? Even the children like CHED, eye syndromes, all those patients we can easily do endothelial keratoplasty, and it has a less learning curve, and this is still mainly practiced endothelial keratoplasty all over. So why then we had to think of DMEK? So because of this interface, and sometimes if you are doing a dissection and you have an irregular dissection, you can have thickness like that. So that is where the DMEK surgery came up. All we have to do is just remove or peel off the descemet membrane from the donor cornea, and then place it, and descemet membrane is removed from the patient's eye, and you transplant this descemet membrane with healthy endothelium in proper orientation, secure it with the air. So you can see the cornea looks pretty pristine. This lady had a multifocal IOL and had TAS. We did a DMEK. She improved to 6, and 8. And you know, sometimes first post-operative day, you don't know that actually there was an endothelial keratoplasty is done. So it's a near ideal transplant because the cornea looks exactly the same. Dr. Basak had published this beautiful paper where he found that rejection rate is almost 1%. So rejection rate will be even lesser than DSEC. So this is how we do, and that is why, you know, because we wanted to transplant only individual layer, that's why, you know, these whole gamut of all these surgeries came up. In beyond, I have just kept a photograph of keratoprosthesis. My acknowledgement to my department at LGI. Thank you so much.
Thank you, Vikas. Only one transplant was left out, which you could perhaps add. That is PDEC, which is again originated from our country. Yes. That's pre-decimate endothelial keratoplasty using the concept of Dr. Dua's layer. So the you do a big bubble, remove the anterior part, and then use what is left behind, that is Dua's layer, that's the posterior stroma, with the decimase and the endothelium. And that in there are published reports, very good
Yes.
prognosis.
Thank you.
Yeah. Horses for